Thank you, Harry. Okay, great to be back. I had my PhD training here in Maastricht, so it's great to be back on the same road from Ghent and Bruges to Maastricht. Yeah. We're going to talk about catheter ablation of paroxysmal AF. This I want to state clearly. It's paroxysmal AF, so we're not talking about persistent. It's catheter ablation, it's point by point. We do cryos, we do surgical ablation, but this is a patient-selected talk. Secrets from the great cooks. Now, it's a bit difficult to start this talk, so I thought, okay, who are the great cooks? And one of them, is Louis still here? Is Ferran Adrià from El Bulli, the top restaurant, #1 worldwide. And he said, si piensas bien, cocinas bien. So it means first think well, and then you cook well. And that gives me less pressure, because it's not the hands. I can go to studies and scientific background. And we have been working the last 2 to 3 years on what we call now the close protocol, in which is, we think, a way to achieve durable PV isolation via the groin percutaneous. And this is work that I did together with Milad Al-Haddad, and it's now nearly accepted. Statistical reviewer is still with 2 questions. I think we're there. And what did we do? Well, we looked at contact force guided encircling. 50 patients. The way people are treated right now in every lab. And we looked carefully. And we asked ourselves, if this is the ablation chain, what are the weakest spots? And we had a lot of parameters, the minimal time for a given segment, the minimal power we applied. It's retrospective analysis. What was the impedance drop we observed? What was the contact force delivered? What was the force time integral? What was the ablation index? Ablation index is a new algorithm which integrates power, time, and contact force to estimate lesion depth. It's a parameter designed by Hiroshi Nakagawa. We also measured the interlesion distance, and we developed software which is called the ablation line continuity index. It's a combination of what we have for lesion depth, and it's what we have for contiguity. So for each of these segments, we determined what is the weakest link. That is weakest link analysis. Then we went back to the patient data, the 50 patients, and we had in those patients 45 gaps, defined as a site where we had to deliver additional energy, either during the first procedure or during late reconnection. This is a gap. I think everybody can accept this as a weak spot in the line. And then we looked at, and this is an example, here you see you infuse adenosine and you see the reconnection of the left superior pulmonary vein. We know that this was in segment 8. Then we look at segment 8, we look at the weakest link analysis, and what you can see, segment 8 could be characterized by a lower ablation index and a larger interlesion distance. That's a representative example, but this is what you get when you do the full analysis. It's too complicated, and I'm going to stick to the 15 minutes, but what you see is that in segments with the gap, first of all, you see that the obtained impedance drop is smaller. That's just an observation, because impedance, it's not a modifiable knob. We cannot increase the impedance with the hands. But what you can do is you can appreciate the difference in the ablation index, that segments with the gap have a lower ablation index, surrogate for lesion depth, and that segments with a gap also have a larger interlesion distance. And if you see those kinds of slides, you can do ROC curve analysis. That's always the same. That's what we do with the specific sensitivity and specificity. But this summarized better what the result is. What we observed is on the left, we took segments that fulfilled all the criteria for contiguity. So less than 5 millimeters is the minimal distance between 2 lesions. What differentiates segment with the gap versus no gap? Well, in those contiguous segments, it's the ablation index that is less or lower in value. And if you do vice versa, you look at segments where all the lesions were supposed to be transmural, then the difference you see is the interlesion distance. So they are independent. We have 2 parameters, and that is the close criteria. And the close criteria are 5 to 6 millimeter interlesion distance is important if you want to have durable PVI. And for the posterior segment, we have to reach a value of 400, and for the anterior segments, we have to reach an ablation index of 550. That is the close criteria. Now, from that Scientific background, we went back to the cath lab, and now we're going to do the procedure according to the closed protocol. And we have been doing this 2.5 years now. And it's standard. And there is a tool which is called VisiTech and AutoTech in the catheter lab where you cannot cheat anymore. Not that we were cheating in the old days, but a tech is a tech. So there are no dislocations when you see a perfect circle, and there is, if you see something sticking out, you have been ablating there. What you see, the color coding, pink is color-coded, that it means that it is more than 400, and red means more than 550. This is the closed protocol. It's enclosing or aiming to enclose the PVs with contiguous, the ELD, remember, and optimized RF lesions, the ablation index. That is what we're doing. This is the scheme. You see on the posterior wall an ablation index of 400, except if there are signs of esophageal injury. Anterior wall, 550. Why we used these criteria, it's clear. It's coming from the analysis of the paper I just presented. Now, this is then the cooking itself, the teamwork. I will not go into detail, but there is really a reason to invite people to the lab. They can learn how to do this because many people are struggling to make this circle. And it's nothing to do with the hands. It's just with workflow. What is the procedural endpoint? I think the big mistake, maybe post hoc, is that we had an endpoint which is PV isolation. Because the PV isolation makes you leave the room too soon. We were happy, and we know it's the correct endpoint, but the way you reach the PVI is probably important. And what we do is, of course, we check the colors, and we check the interlesion distance. We have this tool, which is called the Ablation Line Continuity Index. It's our own tool. It's not from the company. And this is our endpoint. If the circle is complete, you get the PVI for free, right? It's the circle that has to be complete. Now, is this true? And what is the evaluation? This is the second paper, which is now submitted. We compared, as a first evaluation, 50 close patients, that's how we call them, to the last 50 contact force-guided patients. It's not randomized, but believe me, it's difficult to randomize, because once you have seen the secrets of ablation index and whatever, you cannot go back in time. So this is a kind of unique observation in time. It's also the weakness. But here you see, this is contact force. This is close-guided. You see the criteria, the ruler, the ablation index. What are the observations? First of all, what are the patient characteristics? Paroxysmal, yes, all paroxysmal, all highly symptomatic. And look at all the criteria. This is the typical young patient with a small atrium, drug refractory. It's the class 1 patient in the guidelines, okay? So don't extrapolate to other patient populations. That's our patient population. That's most of our patient candidates. Here you see the procedure characteristics. We do a bit of both, general anesthesia and local anesthesia. What you see is that the perimeter of the circle is around 12 centimeters. It's comparable in both groups. But what you see is that the RF time to encircle the veins is much shorter for the right circle, for the left circle. But look at first pass isolation and adenosine-proof isolation. It's nearly 95, 98%. So if we do the encirclement and we check for PVI and we check for adenosine-proof isolation, this is something that is now in 200, 250 patients, it's consistent. We don't see the adenosine reconnection anymore. The big difference, if this is representative cases, the big difference is we ablate with higher watts, because with the ablation index you can drive the power, and your ablation index will monitor your lesion depth. Another difference that I like a lot is that the FTI, remember we had to ablate FTI guided? Well, no, not at all. The FTI can be as low as 200 on the posterior wall. It's even dangerous to go to 400. Also different, what we observe consistently is the impedance drop, suggesting that we have better lesions. This is the software. Remember the ablation line continuity index. You will always see a complete circle, whereas with contact force guided ablation, we had gaps because we had PVI and we left. This is the difference in acute outcome. This is first pass isolation reaching 96, 98%, waiting and adenosine-proof isolation 96 to 98%. These results are considerably higher than the 80% values you see with contact force. What about outcome? This is Holter monitoring at 3 months, 6 months, and 7-day Holter at 12 months. So it's discontinuous, clear. I'll come back to that. But what you see is that the outcome in contact force guided ablation is 80% freedom of AF, and I think that's in line with contact force papers. But in this patient population, in those 50 patients, we have 94% of patients free of a documented recurrence. Now, the next step, what we did is we continued this protocol, and we have now the dose paper ready, which is 138 patients, again, young patients. The only reason why I show these data to show how reproducible our methodology has become and how probably it will be reproducible as well. Look at the perimeter of all the 138 cases. It's around 10 to 12 centimeters for the left, for the right. So you see all the values. Look at the ablation index values. This is the minimal value, so it's the weakest spot in our circle. That's important. You can see for the left circles anterior, we reach the 550. We are not cheating, or we do what we tell. And here we see the posterior wall around 400. So not too much liberty anymore. For the right circles, look, anterior wall 550. So it's an autistic approach, but we always do the same. We always do the same. Here you see the interlesion distance. Look at the interlesion distance. It's 6 millimeters, and this is the weakest link again. So it's the worst spot in the circle. Remember? This is the right circle. Look, we respect the 6 millimeter. This is the 138 patients. We again observe this acute effect, this high rate of adenosine-proof isolation. That is clear also from customers, let's say colleagues using this approach. We see the same acute isolation rate. What about these 138 patients? Well, 10 patients had an AF recurrence with the same follow-up with Holters. And if you look at the 10 recurrence patients, that's interesting. I only have 9 patients with a repeat. You can now see that 6 out of 9 patients have a complete PVI. Dr. Blomström really showed nice data about 10%, 15% with complete isolation. Well, this is again a very objective, for me at least, confirmation that we might be close to a more durable PVI isolation. So 6 patients with a complete PVI, hardly any scar you can see in those patients. So the voltage mapping, we do a lot of voltage mapping. I don't think it will help a lot. 3 patients with classical reconnected veins. So I think that if you go over time, if this is irrigated RF point by point, acute durability and 12-month freedom, and if this is contact force, let's say around 80%, 85%, depending, I think we are somewhere higher. And these are my thoughts, but now I want to finish with 4 to 5 slides. I give a penny for your thoughts, because when I listen to those kind of talks, Harry knows this, then I sit in the room and I say, come on, man, you're not performing enough Holters. Maybe true. Maybe you don't chase AF in case of symptoms. You don't have the time to listen to your patient. Could be true. Maybe we are misinterpreting the Holter ECG. Maybe I'm the only one looking at it. Maybe results are explained by continued drugs. Maybe it's only valid for this single center. Maybe it's a highly selected patient population. Maybe those patients do not have AF before ablation. These thoughts have crossed my mind over the last 10 years. So about the drugs, I think it's important. We have now finished the Powder AF study. The Powder AF study is a study submitted to HRS. Does antiarrhythmic drug have an adjuvant effect after catheter ablation beyond the blanking period? No study has evaluated this, and the result is yes. So if you report the results, you should include the antiarrhythmic drug percentage. It's only in the closed protocol, it's only 30%, but you have to look whether antiarrhythmic drugs are presented. That's the Powder AF. We are doing more. We have now started the VSTAX study. It's multi-center, and all the closed criteria are evaluated in 12 European centers. And the follow-up we do is a copy-paste of the Fire and Ice. I think that is a fair way to have the outcome. The first patient was just treated. My favorite study is the Close to Cure study. It should be even with a question mark. This is a single-center study from our center, and it's patient-controlled. And we evaluate the close by subcutaneous loop recorders, not only after, but also already 2 months before ablation. So they have to wait, and you have to convince the patient. But we will have follow-up with 3 years. We have voltage mapping, we have quality of life, We have 96 out of 100 patients now enrolled in the study. And this is the first time I show this kind of analysis. What you see is the baseline AF, and this is again work I do together with Milad. This is the baseline AF, we call it the AF agenda. You can see that those patients have a lot of atrial fibrillation. So it's the paroxysmal symptomatic AF patient. We do the close-guided PVI. We respect the 3 months blanking. You can appreciate the follow-up, which is of course shortening, because those patients are later ablated. But look, if you would only take that segment 3 to 6 months, we are at this point very optimistic that we are confirming the results we have obtained with the previous studies on the closed protocol. So my thoughts, still conclusions, question mark, an ablation protocol respecting the lesion contiguity, and also Ralph Damiana alluded to this, and lesion depth results in a significant improvement in durability and a high single procedure-free survival at 1 year. A prospective multi-center trial has started. I think that's important. Is there a next challenge? Of course, there is a next challenge, not only in persistent AF, but also in paroxysmal. We have to maintain this high durability while taking away all the overshoot. We are really sure that we are overshooting all the time, right? But that's the typical cut-off guided ablation strategies. How are we going to do it? We're going to measure tissue characteristics in the future, and only then the unique advantage of point-by-point ablation will be exploited to its full potential. I thank you for your attention.
Questions?
I have a question. That was a great presentation. Explain to me how your technique results in less RF time, because I was figuring, well, you know, it would take longer to do it the way you're doing it. How does it shorten the RF time? This comes non-electric.
Good question. The RF time on the posterior wall has dropped to 20 seconds and to the anterior wall on 40 seconds. That's the number one. And the reason is that with the ablation index, we can up-titrate the power, right? So we have shorter application times. We used to have 60 seconds on the anterior wall. Number two, you don't lose any RF time chasing PV reconnections. So that is the two most important drivers of a reduction of an RF time. Yeah.
Other questions? Carina.
What is the procedure time?
Procedure time now, today, in the close to cure, is 2 hours plus or minus 10 minutes. In that procedure, from the 138, we were still at 140 minutes, as you could see. I think we will, I'm not so much interested in procedure time, but if it could be around 120 minutes, I would feel that this is something possible. I mean, it's also important in the cath lab. It's 2 minutes, plus 2 hours plus or minus 10 minutes. Yeah, good question. We do.
No PV stenosis?
So we check for a few clinical signs. At this point in time, we check for clinical complications, meaning the patient comes to the lab and you do a CT. At that point in time, we don't have PV stenosis. In those studies I reported, there is no PV stenosis, but we don't do a CT scan in all the patients. That's number one. Number two, there is a patient out of the study protocol. So I didn't show the patient with the PV stenosis, and this patient had a very small-sized diameter. And I think I personally made a mistake judging the LA-PV junction in that patient. So the question is, PV stenosis for me is a concern. We spend a lot of time defining the anatomy. We will see in the multi-center trial whether this is just one observation. Out of these 250 patients, it's the only complication we had, let's say, worthwhile that name. For the esophageal injury, we do not systematically do endoscopies. So far, we have no issues, but we are really conservative on the posterior wall. If we see signs of temperature rise or the patient complains during awake ablation, then we drop down the ablation index, as I have shown, to 300. And that means sometimes applications of 12 to 15 seconds. But again, I hope that with the multi-center trial, we will be able to show the safety. So far, it's too soon, and it's a relevant question, but it's too soon to draw any definite conclusion on safety. So I have to stay sober on that part.
Matthias, it's just a short question.
Yep.
It seems, when I look to those images, it's not a wide antral isolation, is it? It seems you stick more to the ostium than more of us do.
Yeah. I always have a bit of difficulties defining what is a wide encirclement. I know the paper from Bad Kreutzingen, they compared a wide circle versus segmental. Yeah, and then the wide circle is exactly what we did. But I have the impression that this is indeed, it's a 12, the nice thing is we measure it. So you have to do it, you can do it yourself, and we have a 12 centimeter circle. I guess maybe somebody is ablating slightly more antral, some are ablating slightly more inside. It's 12 centimeter. We can do it on every CT, on every carto, we can do it together and have a look. What is the 12 centimeter for you?